So hello everyone and welcome to this Day With Me session where I'll be discussing few interesting cases of my day. So starting with my first case, so here we have a 50-year-old female with acute pain in the right hypochondrium, and this is the post-contrast CT abdomen of this particular patient, the axial section. I'm scrolling from cranial to caudal direction, and here we can see that the liver parenchyma there is reduced attenuation diffusely, suggestive of fatty infiltration, and anterior to the liver parenchyma in the omentum, we can see there is extensive fat stranding that is seen. You can compare it with the adjacent area, the left hypochondrium. There is fat stranding that is seen anterior to the liver parenchyma in the omentum. Mesentery is all clear here as I'm scrolling down, and then you can see in these coronal sections as well this fat stranding that is seen anterior to the omentum. So what is the diagnosis in this case? It's a case of omental infarction. So omental infarction comes under the broad category of intraperitoneal focal fat infarction, which typically includes epiploic appendigitis, omental infarction, and perigastric appendigitis. Why we have to remember this is because it can mimic acute diverticulitis and appendicitis when it is present in those locations. But the thing is, it is self-limiting. It's a self-limiting abdominal disease where the primary insult is acute inflammation of the intraperitoneal fat. There are risk factors such as obesity, recent abdominal surgery, and trauma. And in this case, this female was very obese, as we can see on the and the liver parenchyma also there is diffusely reduced attenuation, suggestive of fatty infiltration. Another companion case. So this patient presented with acute pain in the abdomen. On an ultrasound, was diagnosed to have left nephrolithiasis, and CT urography was ordered for the same. And what we can see here is there is dilatation of the left pelvic calyceal system. There is a stone here, and as well as in the proximal ureter. But along with that, what we can see is there is a focal area of mesenteric fat stranding. Along with that, there is sparing of the fat around the vascular pedicles. Particular halo is seen, and this fat, this area of mesentery is very well encapsulated. That is, it is seen distinct from the rest of the normal mesentery. So what is the diagnosis in this case? A typical case of mesenteric panniculitis. So mesenteric panniculitis, sclerosing mesenteritis or retractile mesenteritis is a uncommon idiopathic disorder which is characterized by chronic non-specific inflammation involving the adipose tissue of the bowel mesentery. So the thing I wanted to specifically discuss here was Coolier's criteria, which I have discussed previously in my videos of CT, and I have presented this particular case just to stress upon these two important signs, that is halo sign as well as a pseudocapsule, hyperattenuating pseudocapsule that may be surrounding the entire area. These two signs are inconstant but highly specific. Now coming to another interesting case, so this case I learned a lot from this case. So she's a 27-year-old female who came post MTP pills to induce early pregnancy termination. She came with bleeding per vagina, and on this follow-up scan, mainly done to look for any retained products of conception. This is the scan that I did, and this is the measurement of the right ovary, and it is within the normal limits. This is the measurement of left ovary. You can see some follicles as well, and this is the endometrial thickness. There's no free fluid in the POD, no pelvic free fluid, no tenderness, no pain abdomen, just some spotting, and UPT was positive. So she was very inquisitive, and she was asking why the UPT is still positive when she has actually induced she has actually taken MTP pills and there is no RPOC. So I thought that the UPT is positive because it will be positive for some days after MTP pill intake. So because of that, it might be possible that the UPT is positive. There is no signs of any retained products of conception. So I called her after 1 week for a follow-up scan. So as there was no retained products of conception, no reason to worry as such, She went back home and she came back with again the same complaint after 10 days. That is bleeding PV and UPT was still positive. So that was something that should not be present at this point in time. So I again did the scan. I didn't find anything. I got a CT scan done, and on CT also I didn't see anything. Then what I thought that let me just look at the TVS. So I did a TVS for this particular patient, and on TVS this particular thing was seen in the right ovary, within the right ovary. Typical uh, color uptake was seen in the right ovary on TVS, and retrospectively on TAS again when I focused on the right ovary and I put the color box there, there was a particular waveform that was seen, which was suggestive of a live ectopic ovarian pregnancy. So it's a rare case, but the possibility of this case should be there in the mind to focus on the right ovary. There was no POD collection, no pain abdomen, but still she was having a live ovarian ectopic pregnancy. So ovarian ectopic pregnancy is less than 3% of the ectopic pregnancies, and the risk factors include pelvic inflammatory disease, IUCD, endometriosis, in vitro fertilization, embryo transfer, and previous adnexia. So on asking, she had a history of pelvic inflammatory disease in the past. So this is a very interesting case that I wanted to share, and so that we are well aware of such possibilities in future. Now coming to my next case, again this patient presented with acute abdominal pain in the right hypochondrium, and this is the post-contrast CT axial section of this particular patient. So what we can see here is, as we are scrolling down, we can see that the gallbladder, we can see some calculi within the gallbladder, hyperdense calculi, and there is perforation of the wall of the gallbladder along with pericholecystic abscess formation. You can see this abscess formation that is there along with mesenteric, extensive mesenteric fat stranding, the pericholecystic abscess formation and perforation, discontinuity in the wall of the gallbladder, that is very well seen. So in this particular case, yeah, we can see small hyperdense calculi. I wanted to discuss, so I mainly wanted to discuss about Nemeier's classification in this particular case. So gallbladder perforation is not a very common complication. It's a serious complication of acute cholecystitis and usually occurs in elderly patients with comorbid conditions. So in Nemeier's classification, there are four types, where type 1 is acute free perforation, type 2 is subacute pericholecystic abscess, which was our case, type 3 is chronic cholecystoenteric fistula, and type 4 is cholecystobiliary fistula formation. So now coming to my next case, she's a 22-year-old female who presented with severe headache and convulsions, and this is the NCCT of this particular patient, where we can see gross dilatation of bilateral lateral ventricles with transependymal periventricular edema, and then there is a soft tissue density mass with multiple calcifications and a large dense central calcification that is seen in the pineal region. We can see that there is obstructive hydrocephalus that is very well seen, and in the pineal gland region only we can see that there is a soft tissue density mass lesion. MRI was also done for this patient, and this is the MRI picture of this patient. You can see on these unweighted images that there is a mass lesion that is seen, transependymal periventricular edema. So it's a typical case of pineal germinoma. So pineal germinomas are the most common tumors in the pineal region, accounting for 50% of all the tumors and majority of the intracranial germ cell tumors, that is 80% of them. And they cluster in the midline with predilection to the pineal and the suprasellar regions. Pineal being the most common, and next common is the suprasellar region. So another important tumor is pineoblastoma. So how do you differentiate pineal germinoma from pineoblastoma? Pineal germinoma usually has central dense calcification, while blastoma has peripheral calcifications. So now coming to the next case, which is actually a spotter case. So this patient presented with abdominal pain and signs of intestinal obstruction, and this is the axial CT section of this particular patient. I'm scrolling from cranial to caudal direction. So as we can see that there are some dilated bowel loops that is seen. Along with that, some nodes are seen in the mesentery. Some thin capsule or peritoneum is seen surrounding these dilated bowel loops, along with some fluid that is present, and we can see that thin peritoneal fold that is actually covering. You can see this covering the bowel loops, thin peritoneal membrane covering the bowel loops, and they are clustered in the midline in the abdomen. This is the coronal section, the same patient, where again you can actually appreciate that thin peritoneal covering and the cluster of the bowel loops along with the fluid, the dilated bowel loops along with the fluid, and some mesenteric lymph nodes. Let us see. So it's a typical case of sclerosing encapsulating peritonitis. So sclerosing encapsulating peritonitis, also called abdominal cocoon, is not only caused by TB, though in India it's mostly because of TB, but it can also be caused because of multiple other etiologies. It can be idiopathic, or it can be secondary to peritoneal dialysis, ventriculoperitoneal shunts, sarcoidosis, familial Mediterranean fever, proteinase deficiency, and liver transplantation. So you have to keep these things also in mind. Now coming to my next case, so this patient presented with left-sided back pain. She's a 25-year-old female who presented with left-sided back pain. And as most of the cases, LS spine was ordered for this particular patient, MRI LS spine, and the technician was good enough to pick up some abnormality in the sacroiliac joints. So I asked him to get the entire thing done, all the sequences, including the STIR and T2 sequences of the sacroiliac joint. So we can see in that in the left side sacroiliac joint, both on the sacral as well as the iliac side, we can see hyper intense signal on STIR as well as on T2 weighted images. So this is the intraosseous ganglion cyst on this side. So on right side it is completely normal, there is no such signal change, but on left side there is hyper intense signal on both the sides of the joint, which is suggestive of a unilateral sacroiliitis. Now coming to the differentials for bilateral symmetric, bilateral asymmetric, and unilateral sacroiliitis. So bilateral symmetric sacroiliitis includes ankylosing spondylitis, IBD induced sacroiliitis, rheumatoid arthritis, and bilateral asymmetric sacroiliitis is typically seen in psoriatic, reactive, gout, osteoarthritis, Behçet's disease. While in case of unilateral, it can be either because of a neoplastic process, infective etiologies include septic arthritis, IV drug use, tubercular sacroiliitis. So this patient has had a history of pulmonary TB, and now she was having pain. So it was a typical case of tubercular sacroiliitis. And also brucellosis can cause unilateral sacroiliitis. So this is an important thing that we should keep in mind while considering the DDs for sacroiliitis. So now coming to my next case, which is again an interesting case where a 49-year-old male presented with right-sided weakness since the past 4 days and one episode of convulsion. And this is the non-contrast CT scan of this patient, axial section. Scrolling from cranial to caudal direction, now we can see that there is some extensive vasogenic edema in the white matter, parietal white matter, and there's some lesion that is seen in this particular region with a subtle area of hyperdensity. So it was given as a space occupying lesion on non-contrast CT, and a contrast study was advised, and this patient went ahead and got a contrast enhanced MRI done. So now this is the MRI picture of this patient. So this is the T1 weighted images where we can see a large area of hyperintensity with a area of hypointensity within it. And these are the T1 post contrast images because we are suspecting a space occupying lesion. And on post contrast image, the area looks the same as on the pre contrast T1 weighted images. Then these are the T2 weighted images. Again, this area appears intensely hyperintense throughout with surrounding vasogenic edema. And these are the flare images where we can appreciate the edema very well, and this hyperintense area remains that is seen. And these are the DWI images where we can see that there is hyperintensity in within the particular lesion, and it is showing hypointensity on the corresponding ADC map, suggesting area of restriction. And then again there is surrounding vasogenic edema that is very well appreciated. These are the SWI images where we can see peripheral blooming and another area of blooming that is seen in the right capsuloganglionic region. So all this was quite confusing, and it was difficult to determine whether it is actually a mass lesion or only a hemorrhage. So we also got a MRS done in this particular case, and there was no choline peak and NAA peak was preserved. So the diagnosis actually in this case is a late subacute hemorrhage, and this table of Osborne will definitely help you to come to this particular diagnosis, where the late subacute hemorrhage typically is hypodense on CT scan and appears bright on T1, T2, and also on the DWI, and it definitely shows a dark rim as was seen on the SWI images with a variable center. So some of the practical important points that I gathered from this particular case was that subacute hemorrhages can appear and mimic mass lesions, and a high degree of clinical suspicion is hence required to diagnose it accurately. In this particular case, I did not get a proper history from the patient. I had to elicit that history of hypertension and the acute history of weakness. And in such cases, it is very difficult to actually, because it will appear as hypodense on NCCT as well and with surrounding vasogenic edema. But MRI definitely is very helpful in such cases, and MRI to look at all the sequences and make use of all the sequences is actually very, very important. Because I started with the post contrast images, which actually looks like intensely enhancing solid mass lesion in the parietal lobe. You'll get confused as to what exactly, and you'll think in the lines of a neoplasm. But in this particular case, if you look at the T1 weighted images, you can see that the same lesion is seen hyperintense on T1 weighted images as well. So it was not any contrast enhancement that was seen. Another important learning point is hemorrhages also show restriction on DWI. Make use of all the sequences that you have, T1 weighted images, T2 weighted images, flare, all the sequences give some important information. I also did a MRS in this case to actually, because I was thinking in the lines of neoplasm as well, because I was thinking that there is some neoplasm that is having some hemorrhage within. And always advise a follow-up in this case, because if there is some neoplasm that is there underlying, can be detected. So this is CT PNS of a patient who's planned for FES, and I have just kept this picture to discuss about the preoperative checklist for a patient planned for FES. Here we can see that there is a complete blockage of the left osteometrial complex and chronic sinusitis on the left side. On the right side, there is mild sinusitis with thickening of the mucosa. So preoperative imaging essential components can be remembered with a simple mnemonic close, that is cribriform plate, lamina papyracea, Onodi cell, sphenoid sinus pneumatization, and anterior ethmoidal artery, which are assessed in these particular planes. The cribriform plate, we typically give Kiros classification type 1 or 3, type 3 being the one with highest incidence of CSF leak. Asymmetric Kiros has to be mentioned. Any bony dehiscence in the skull base has to be mentioned while looking for cribriform plate. Then lamina papyracea, any remote orbital fracture, orbital prolapse into the ethmoid sinus, which I have seen. Presence of Haller cell, which is very common. Uncinate process contacting the orbital wall. Onodi cell, presence or absence of Onodi cell typically has to be detected. Dehiscence of the optic nerve within the Onodi cell, which can cause injury to the optic nerve while operating. Sphenoid sinus pneumatization. Pneumatization pattern has to be mentioned in all the reports. Conchal, presellar, sellar, pneumatization into the skull base and anterior clinoid, dehiscence of the carotid canal, sinus septations inserting into the carotid canal, optic nerve dehiscence within the sphenoid. Then anterior ethmoidal artery to identify the ethmoidal notch and the presence of supraorbital pneumatization. Now coming to some variants that affect the OMC, which include Haller cell, concha bullosa, paradoxical rotation of the middle turbinate, nasal septal deviation, and paradoxical uncinate, which have to be kept in mind and have to be reported. Some surgical complications of FES include arterial vascular injury, that is to the anterior ethmoidal artery, orbital nerve injury, orbital hematoma, CSF leak, and nasolacrimal duct injuries. These are all major complications. Another important thing that should be included in the report is the pattern of sinusitis, whether it is infundibular pattern involving the ipsilateral maxillary sinus, osteomeatal unit pattern involving ipsilateral anterior group of cells, that is maxillary sinus, anterior ethmoidal cells, and frontal sinus. There is a sub pattern in this particular unit, that is frontal recess pattern only involving the frontal sinus, that is involving the frontal sinus drainage pathway. The sphenoethmoidal recess pattern, which involves the ipsilateral sphenoid sinus and the posterior ethmoidal sinus. Sinonasal polyposis, where there is a diffuse involvement, and the sporadic pattern, which is quite common. There is a random involvement of a single sinus or multiple sinuses. Now, this is the infundibular pattern of involvement, where there is obstruction in the infundibulum and some mild sinusitis. This is the osteomeatal unit type of involvement, where the complete osteomeatal unit is involved and there is all anterior group of sinuses are actually involved, the frontal sinus, anterior ethmoidal layer cells, as well as the maxillary sinus. This is the subtype of 2, where there is a frontal sinus drainage pathway that is involved and leading to frontal sinusitis. Then comes the sphenoethmoidal recess pattern of involvement and sinonasal polyposis. So now time for a quick spotter case. So spotter means all the information that is required for the diagnosis is there within this particular image. So I'll just scroll from cranial to caudal direction in this HRCT thorax of this particular patient, and I want you to actually comment the answer in the comment section of the video below. And look at this particular video scan of this patient, HRCT scan. Okay.